This podcast is sponsored by Eli Lilly.
I can make you not itch. I can make it look better. I can make you feel better. And not just the skin feel better, I can make you feel better all over.
Questions do you ask, or how do you try to get an idea of how their psoriasis is affecting them?
Right. So the first patient you identified of not wanting to have intimacy with your partner because you're embarrassed by the genital psoriasis, or your partner is scared of the genital psoriasis. It's important for patients to understand that anxiety, depression, and SIB is part of the disease process.
Welcome to Derm-It Trotter, Don't Swear About Skincare, where host Dr. Shannon C. Trotter, a board-certified dermatologist, sits down with fellow dermatologists and skincare experts to separate fact from fiction and simplify skincare. Let's get started.
Welcome to the Derm-It Trotter, Don't Swear About Skincare podcast. I've got a very special guest on the show here today, Dr. Scott Drew, who is my program director in residency training. He practices at Dermatology Associates of Mid-Ohio, and he's a board-certified dermatologist and on the medical board for the National Psoriasis Foundation. So needless to say, psoriasis is his thing, and that's what we're going to tackle today with mental health. Welcome to the podcast, Scott. It's great to have you here.
Well, thank you, Dr. Trotter. It's great to see you again, and always fun to talk about psoriasis. We could have a podcast for hours because psoriasis is such an important disease, and we actually have ways to make people get back to life and away from their psoriasis.
Well, I have to credit you because you taught me everything I know about psoriasis and not to be afraid to treat the patient, and not just their psoriasis, but the whole patient. You know, you really emphasized that when we were going through a clinic, and really just understanding how psoriasis impacts patients beyond just their skin. You know, the emotional toll that it takes on people, it takes them out of life, it takes them out of their activities as well. So I wanted to know if you could talk about that, what you've seen with patients and really how psoriasis has impacted their life.
So I don't know if I have ever talked to someone about their psoriasis without getting some response by sentence 2 or 3 that implies some degree of diminution of their quality of life, whether it is work related, whether it's embarrassment, whether it's intimacy issues. Once you drill down into why they're there, the word embarrassment or ashamed or what have I done wrong or what I've missed, why I didn't go to the sorority party, why I didn't go on that job interview comes up. And I think we're doing our patients a disservice if we don't acknowledge that. When a patient is sitting in the chair across from you and you watch their eyelids, their headlights dim, they look away from you. When you see them fidgeting and being distracted, it's the body language clue. And the reverse of that is when they come back for their second or third follow-up visit and they're engaged and they're open and their hair's done and their nails are polished and their shoes are shined. You know that they feel better about themselves and they're ready to present themselves. I mean, this would never happen in my generation, but you know, I've had people come back on their third or fourth visit and gotten a tattoo because they want to express their pride in themselves. And you can see when they're walking down the hall to the exam room, the change that they've experienced. And the flip side of that is on their first visit, I've often been their 5th or 6th or 7th dermatologist and their 12th or 13th physician. And you know, they say, well, I was given a cream, or I was told, you know, I'm too fat, or I smoke too much, or, you know, your dad and mom had it. And but you know, it's just skin. So, you know, you don't have brain cancer. So just suck it up. And, you know, we've all seen people who leave a trail of scale when they undress in your office. And that's just such a shame. And we hear their stories about what they don't do. I mean, I've had kids that have gone to college virtually because they don't want to go into a classroom. I've seen kids that don't play sports because they don't want to undress in the locker room. And they've been told time and time again that these drugs aren't safe, it's not very effective, you know, creams are so much safer, which again is ironic because we all know that's not the case. So I think the amount of joy we can bring to a patient, and if you think about it, a long, long time ago, there was no quality of life data in any pivotal trial or research. And try to get an FDA to approve a drug in these days without a quality of life component, not going to happen. We recognize that different populations have different quality of life measurements, and whether it's a skin tone, whether it's a gender, whether it's an age, whether it's a specific demographic, different quality of life measures matter. And what I find is very, very important when you're talking to a patient is for us to pitch the ball about mental health, to make it, we don't have any trouble saying, hey, do you itch?
Right.
Does it bother you when your ear is draining and oozing? I just right up front say, does this ever make you feel bad? Does this make you blue? Does you get depressed about this? Because if you discuss it like it's an AE of the disease, people are willing to talk about it. It's just like saying, do you have it on your feet? Do you have it in your intertriginous areas? Is it in your pelvis? Oh, well, now that you bring it up, I do. That must not be too out of line. So I'd like to just address the mental health component up front so that they know I get it, that they know I'm on their team, I'm their ombudsman, if you will, or one of them, and that allows them to feel comfortable having the conversation up front that let's talk about all the things that are bothering you about the psoriasis, because there's nothing, there's no topic that's off limits that the diagnosis and the therapeutics can't work together to fix.
Yeah, and I think people should feel comfortable, talking about that with their dermatologist. They might think, oh, well, I'm just here for the skin part of the psoriasis, right? And maybe the mental health piece, that should be my family doctor. Maybe if they already see a psychiatrist or psychologist, that gets relegated to them. And I think, what you're pointing out is really important, that people understand that your dermatologist gets that this affects, how you feel emotionally, your ability to go to work, like you said, your ability to be intimate with your partner, your ability just to enjoy life and be out there in the game of life. And that's actually what inspired me to go into dermatology. A patient had psoriasis all over his body. Biologics were just coming out, and he cleared, and he actually got off disability, and he was dating by the time I left. And I thought, wow, his life did a complete 180, and how impressive that we could be a part of that as a dermatologist. Now, when you've had a patient come in, and obviously you're looking at their skin, addressing itch and the psoriasis, tell me about, someone maybe you recognize that clearly they were struggling with some symptoms of anxiety or depression. Maybe they didn't even recognize it themselves. And how do you approach that, with a patient, or how would you tell a patient to bring it up to you? Because I think that's the piece, that crossover, is how do you have that conversation even start?
So I think it's important that you feel comfortable, we, the providers, feel comfortable and confident in our ability to make their lives better and present it as, I can make your skin feel better. I can make you not itch. I can make it look better. I can make you feel better. And not just the skin feel better. I can make you feel better all over. Because we used to think of psoriasis as a skin disease. And we all know it's a multi-system pleomorphic disease that affects lots of things. And we address people like, you may be insulin resistant. You may have dyslipidemia. You may have anxiety and depression. These are all parts of psoriasis. And as soon as people recognize that this is not something they did, ate, smoked, or thought, this is part of the disease process. And then the door cracks open. And oh, Shannon, I could tell you I think like any dermatologist can tell you stories of people who don't go on job interviews, who don't go to the sorority party, who won't date, who only wear clothes that are long and billowy, and because they're embarrassed, they're ashamed. It's like somehow something I did something, and this is the penance I have to pay. And I think it brings me a quality of life improvement when I can disabuse them of that notion. I have a great story of a guy. I live very near the Great Lakes, and I have a patient that is involved in the boating industry. And on a boat on Lake Erie, I can tell you, people wear very small bathing suits and always have a beer in their hand. And, they maybe do things we don't want them to do with the sun on a boat. But this,
we know you've got a Speedo, Scott. We know you got one.
oh my God. And so this gentleman always wore long sleeves, always covered himself up, always wore shoes on his boat because he was so embarrassed about what he did. And his career was a charter boat captain, and he also maintained and sold boats. And every other person that does that has a certain uniform they wear. And he didn't fit in. And he was always the guy with the long pants and da-da-da-da. And you know the story. I met him. We worked together up at Lake Erie. And at one point, I saw him in short pants when he didn't think anybody was around. And I said, we can't have that. And he thought he was burdening me. And I said, everybody knows we're friends. And if they see that skin, they're going to presume I'm your dermatologist. And look at you. You look like hell. We can't have you looking like that. And so we got him started on the appropriate therapeutic regimen. And I'm telling you, he is a different human being. He was single. He wasn't dating. And now he's had the same partner for, 7 years. And it's opened up an entire new quarter to his life. And every time he sees me at Lake, he buys me a beer. And that's not why I'm treating him. But it's just, I have a new friend because he's been told forever, it's just psoriasis. It's just your skin. And that reminds me to remind our colleagues, if I'm giving a formal lecture or talking to medical students or residents, people sometimes say, well, I don't want to do this because you can have to have a blood test. I'm like, well, of course you need a blood test. You're a psoriatic patient. You probably have metabolic syndrome, or you're on your way to metabolic syndrome. So you need to make sure all those things we talked about are tended to. And when you get that patient who's got PASI 50, 60, 70, 80, and you give them the appropriate treatment, because we have so many now that are good and effective and safe, you can pretty much say to a patient, I'm going to make you better. And then they say, oh, yeah, right. You're my 10th dermatologist. And I'm going to be your last one, too, because I'm going to take care of you. I really, not that I don't give them a choice, but I look in their eyes and say, we're going to change the way you look at yourself. And we have to get rid of the blame. We have to get rid of the shame. And we also have to, part of that, to accomplish that, we have to get rid of the stigma that a small molecule or a shot is, not some immunosuppressant that's going to kill you. And I tell people, your immune system is working crazy overtime, and we need to regulate it. We need to immunonormalize it. It's a phrase I'm stealing from one of our colleagues, not mine. But I like that phrase, immunonormalize. Your immune system's crazy, so I'm going to connect it.
Hold on just a minute. I'm going to pause it. You cut out for like a brief moment. Is your internet strength okay where you're
at? I think so. It says
okay.
99%. Yep.
Okay. All right. It cut out. It may just come across on my side, but not on the other side. So we'll look at that. No worries. They'll cut this portion out. So, I think then for somebody who has psoriasis, I think you could definitely feel like or have the notion that obviously it's probably affecting them from a mental health standpoint. But how do you approach that with a patient? Now, clearly somebody might come out and say, oh gosh, Dr. Drew, like I can't even go to work. Like it's just about, I'm so embarrassed. I want people to see my skin. But for somebody that maybe it's not so obvious, how do you sort of tease that out? What sort of questions do you ask, or how do you try to get an idea of how their psoriasis is affecting them?
Right. So the first patient you identified, that's easy. They're bought in. They come in saying, what kind of Girl Scout cookie can I buy? You know you're making the sale. But more commonly, if a person comes in with a spouse and the patient says, oh, it really doesn't bother me, and the spouse like smacks him on the shoulder and says, yes, it does, because you have blood on the sheets every morning, you're up at night scratching it, and you wake up at 2 a.m. and put lotion on, it does bother you. Yeah, it does. And, getting an old guy to admit he's blue about something is very, very tough. So I always make a point, and this may sound somewhat controversial, but I always touch the patient, and I always touch them where they have a big, thick plaque. And I pet their psoriasis. Like, I'm not scared of you. I don't think you have leprosy. I don't think, Your psoriasis is not contagious and you shouldn't be scared of it. You have psoriasis. You are not a psoriatic. And I sometimes I say that phrase, and I look in their eye and I say, "Oh, we need to get rid of this. I know it bothers you," and I tell them things that I hear commonly from other patients. Man, you must sometimes not want to like wear flip flops because your toenails are full of the signs of psoriasis. I can get psoriasis in my toenails. And I grab their foot and say, "You see these little dents in them? Those are called pits, and we can fix that. And see how it's cracking at the end? That's called onycholysis. We can fix that for you." Oh. And I said, and those interleukins, those funny words we talk about, they can land in your joints, and they can really destroy your joint. We make that better. And I try to loop in heart and joints and skin and lipids and make it all part of the conversation so that it doesn't have the stigma of mental health issues. We can walk into a lecture or a party and say, I don't feel very good today. I hit my elbow and I have to have injected. And people go, oh. But you can't walk into a party in 2026 and say, "Oh, when did I come tonight? Because I had some suicidal ideation and I didn't really think it was appropriate." Because we as a society don't talk about mental health, at least very comfortably. So I like to just put it out on the table. You might not like anchovies, but they're on the buffet if you want one. And so we just flat out say, I'm sure some days you get out of bed and you look at your knee and it's a mess. You just feel depressed and don't want to do stuff. And they go, "I don't." And if you don't run out of the room screaming because you're afraid of them, that makes them feel like they can trust you and that you get it and they are not your first psoriasis patient. And when you empower them, I have heard some of my colleagues say, "Oh, my patients would never do that." I'm like, really? Because if you do enough research and do your homework, I think that most patients they're coming to you because they want you to make them better. And if you convince them that you have the tools to make them better, they will work with you to use those tools. Now, it may take a little more time to talk about SIB or whatever side effect they're worried about. And that I think that will help them buy into the therapeutics. But I think the key is that you have to acknowledge that mental health issues are there. Now, I'm really mainly talking about anxiety and depression, perhaps some suicidal ideation. The numbers for like the serious, the ultra serious schizophrenia, those numbers are higher, but still in the low single digits. The depression, anxiety numbers, they're well into the 20s, 30s, and 40% of patients. But it's not a steady state. It's not homeostatic. I mean, one day you're on vacation with your family, you're at the beach, you're okay. But one day you're at work and the new kid comes in and he's young and virile and doing hoops and playing ball, and you got joint pain. Well, that may flare up a little bit. So I think it's an ongoing conversation. So someone's got dyslipidemia from their part of their metabolic syndrome, and so they're being treated by somebody. They don't think about their cholesterol every day. I mean, they maybe think about it if they get an ice cream sandwich or something. But the joint pain of psoriasis, the blueness of not being able to get out of bed in the morning, the anhedonia of not wanting to have intimacy with your partner because you're embarrassed by the genital psoriasis, or your partner is scared of the genital psoriasis, or perhaps the patient's spouse or partner isn't aware of it and thinks it's not psoriasis but something else. And that just adds to the mental health depression. We have to hit this ball right in the strike zone and discuss it, not like it's a stigma, but that it's a symptom. And when the psoriasis and the plaques go away, people feel better. So it's when I give a talk about psoriasis and get to the side effects section, I always start with, what is a side effect of doing nothing? And yes, we have side effects of we have MACE events, and we have DVTs, and we have joint pain, and we have injection site reactions. All those things are side effects, and they're in the percentage numbers that we all know about. What we don't know about, what is the risk of SIB for a college-age kid who's got psoriasis? He's the only kid on campus who knows he's got psoriasis, and we just say, it's really not that bad. Just put some Triamcinolone on it, and I'll see you in a year.
Mm-hmm.
We have to acknowledge, remember what it was like when we were in college. Oh my gosh, it's the first warm day of summer. Let's go out to the college green and get those inflatable pools and jump in the pool and have a beer and try to impress the sorority girls across the street from us. Well, that's going away when you've got plaques on your elbows, knees, face, scalp, ears, and fingernails. So I think the acknowledgement of the impact that it's just skin disease has on people. And there are websites. The NPF has websites for parents that they can go to. They have the AAD has partnership programs for where patients can meet other patients and understand that they're not the only patient on the planet that's got psoriasis. Now, sometimes that gets out of hand, obviously, because they come in and say, hey, I read the teacher, it will fix my psoriasis. and what's the root cause of my psoriasis? And that can go down a rabbit hole, obviously. But I think it's important to empower people to talk about it, and people bond and become friends over their shared experiences. Mm-hmm. And I think it's important that we empower that as well.
Well, one of the things I wanted to pull out from what you just talked about is you mentioned side effects, right? And how that sort of makes some people pause. And I feel like in particular with psoriasis, because some of the medications that we know that work very well, they might see listed in the clinical trials or where they were studied that patients did report depression, anxiety, or thought about committing suicide. Or maybe we have a medication, obviously, where there was a completion of a suicide. We've seen this before, in trials. A lot of patients then automatically jump to the conclusion that, it must be the medicine, right? So I was going to have you kind of help fix that sort of perception, because some of our listeners out there, I think, kind of think that way, versus the fact that we know anxiety, depression, 1.5 times, greater risk of developing that in patients who have psoriasis versus those that do not. And then also just maybe some evidence of the same inflammatory cytokine profile that, fuels psoriasis may actually help fuel depression and anxiety as well. So I was going to have you comment a little bit, because I think that's something we need to clear the air on, that might help some of our listeners that have been hesitant to do therapy because they might be thinking it's going to make depression and anxiety worse based on what they've heard.
Well, you have just opened Pandora's box, and I am.
I always do that at the end of the podcast, just for fun.
I am so happy you said that, because so first on the inflammatory part of this, back in my residency, we all thought psoriasis was caused by too much S1 of mitosis. And if you somehow fix that, you'd be fine. And now we know that this is this multifactorial inflammatory cascade of events. Well, that same series of events is happening in many, many, many systems. Well, of course, it's happening in the central nervous system. So, and there's lots of ongoing studies that are in style or in process now to validate that. And we have plenty of evidence that depression and anxiety goes down directly proportional to your BSA and your PASI score. We know that. And so I think it's important for patients to understand that anxiety, depression, and SIB is part of the disease process. And how you do that is by talking about it and understanding among our colleagues. Again, as I said earlier, when I was a resident, nobody cared about quality of life. Right. Suck it up. And now we know that that's not the way it is. Now, I'm not suggesting that we somehow empower this cocoonness. In fact, I tell people, if someone makes fun of your psoriasis, that's on them, not on you. That just shows their lack of understanding and lack of compassion, lack of empathy, and lack of intelligence. And I try to let people know that you are bigger than this disease, and it's my job to help you be taller, be stronger, be faster, be wiser with this disease that you have, because we have so many safe tools. And I think it's important that our young resident education programs continue to aggressively educate these young providers on the totality of the patient experience. Because again, they've been told time and time again by providers, eh, eh, and educational programs for non-derm providers, the people that send patients to us. I don't think everyone needs to know about every single IL-12, IL-23, IL-31, IL-4, IL-13 JAK inhibitor. That's, non-derms are busy doing their own thing. But I think it is important for us to talk to those groups at county medical society meetings or national PEDS or national FP meetings about safety, efficacy, availability, mental health issues, so they know they can come to us and bust some of these myths that, oh, your drugs are immunosuppressive or pro-infective. The biggest reason my patients stop drugs is they've been told by their surgeon of whatever specialty that I don't want you to get an infection post-op, so we're going to stop your drug for the next 2 to 4 to 6 to 8 to 10 weeks. And I tell patients, do not stop anything unless you ask me first. And if there's some conflict, then I pick up the phone and call the relative person to that. But I think was there a part I missed about your question? I think it was one other thing I wanted to say, but I forget what it was.
So I just asked about like the medications, like how people blame the medication causing depression, anxiety. Because I do think a lot of people think, when they see that as a side effect or an adverse event listed.
Yeah. And so it's interesting in the post-marketing data, the most common drug, or the drug that most commonly has had suicidal ideations is adalimumab. And that does not have a box warning or any warning about suicidal ideation behavior. And that's, first off, it's been around the longest. You might actually assume that. But the newer drugs, like the 2.0s and 3.0s and the 17A class or 17AF class, their post-marketing suicide rates are far less per capita. And I think it's important for us to put guardrails around AE understanding, because it's kind of like saying, oh, don't worry about that office on the 4th floor. There's no bombs up there, so don't worry about that. Well, immediately everyone worries about what's going on the 4th floor. So I think it's important when we say to patients, psoriasis makes people depressed, and some people who are depressed think about suicide. We're going to make you not depressed because your psoriasis is going to be less, if at all, present. Because the NPF guidelines are 99% clear 99% of the time within 90 days of treatment. And so we're supposed to be empowered to tell people that on their first visit. And unless there's some pre-existing organic depression, when they hear that, they're like, wait, in 3 months, I'm going to be clear the vast majority of the time? What? I mean, you get a visceral emotional reaction from them. You mean I'm going to be better in time for my bathing suit? And they're incredulous. And so as long as you understand the data and give them the data, I think it's a pretty easy conversation to have. Now, I got to tell you, some of these drugs have REMS programs and some have an SIB warning on them. That makes it a little more difficult and makes your visit longer because you have to extrapolate that a little bit. But if you look at the forest, not the tree, your second, third, and fourth visit are so much quicker because they get better. You walk in the room, how you doing? I am great. How's your stress? Oh my God, I can't believe how good it looks. Are you feeling blue? Have any side effects? Do you have any conjunctivitis? Do you have any joint pain? Do you have any infections? No. I want to be in this forever. It's a quicker visit. So I think if you look at it on a global perspective, it's a much easier drug to write. And then they tell 2 friends who tell 2 friends who tell 2 friends, and all of a sudden your appointment schedule's filled. So I don't really buy into the I don't have time to write these advanced therapies, because I think if you invest a little bit of time at the front end, the back end pays for itself.
Wow, that I think that's so important for people to understand. And, kind of as we just wrap up here, I always learn so much from you, Scott, even now. It's so funny going back to training and even the new things and insights that I get from having conversations with you about patients. But I want you to leave our audience with kind of what your messages of hope, for somebody who's struggling with skin condition, psoriasis, hidradenitis suppurativa, for those people that are dealing with mental health issues related to, and maybe sometimes even separate, they could have existed prior. What is your message of hope for our audience out
Yeah.
there?
So, HS is a different disease. I can't deliver the promises for HS that I deliver for psoriasis.
Mm-hmm.
But for AD and HS, I can. AD and psoriasis, I can. And for HS, I can certainly give the promise I'm going to make you better. But in 2025, there's no time in human history that's better to be a dermatologist, because we can offer hope to every patient who walks in that door. I mean, I don't think there's a single patient on the planet that isn't a candidate for one of these advanced therapies that will not get better, particularly psoriasis. And when you have a patient tell you about their story of how their life has changed. I was able to go to my daughter's FFA competition. My son got married. My granddaughter had a bar mitzvah, and I was there to watch this. And I couldn't have done it before. Thank you, doctor, for helping me do this. And you tell another patient that story. Like, I used to love bowling, but I can't because my finger won't fit in the bowling ball hole anymore. Like, we can help you with that, because they've been told so often. So hope is the word. Hope and the promise of improvement. So and Shannon, I have to tell you, I am so proud of you. I can't turn on the internet without seeing you lecture in Hawaii or in Florida or writing a paper, or it gives me great glee to sit around and watch an expert panel, an acclaimed expert panel, and you are sitting on it. It's just like makes my day. So congratulations to you and your beautiful family.
Well, thank you so very much. And thanks, Scott, for coming on the podcast. Always love getting your insights. I know your psoriasis patients, I mean, you've made such a difference in their world and their lives. And I know they're incredibly lucky to have you. And so is our audience for having the opportunity to listen to your insights today. So stay tuned for the next episode of Derm-It Trotter. Don't swear about skincare.
Thanks for listening to Derm-It Trotter. For more about skincare, visit dermittrotter.com. Don't forget to subscribe, leave a review, and share this podcast with anyone who needs a little skincare sanity. Until next time, stay skin smart.